Here's some evidence about why these policies are so important. I remember specifically hearing years ago about an infant who was scratched by an older child who came from another room where the older children were kept, and because I believe there weren't enough personnel available to supervise, that older child went to the room where the infants were and seriously scratched that child, the infant.
I know, I understand.
And we have incidences like that happening, so we have to be very, very careful. I look forward to the testimony.
Just call me Daddy Daycare.
Yeah. Okay, Daddy Daycare.
Yeah.
Thank you, Senators, for your questions. Senator West will leave Senate Bill 1269 pending. For those in the audience wishing to testify on this, it is the bill with the most number of individuals wishing to provide public testimony, so it will be the last bill probably that will have public testimony. Senate Bill 1269 is left pending. Chair lays out Senate Bill 577 by Senator Perry. Recognizes Senator Perry to explain the bill. We do have a resource witness from the Texas Optometry Board here as well, Chris Claris, that we'll probably call up.
Thank you, Mr. Chairman and members. I'm going to have a little bit of a lengthy layout and a comment up front regarding scope practice issues in general. As state legislators, we're always in the crosshairs of scope issues. It's a good day for me because this will probably be my last scope issue bill for whatever tenure the voters and the good Lord choose to let me have. You know, as legislature, we look at several things when we go down the scope issue road. One is public safety, and probably the foremost. Two, we are brought new classes of people doing same duties that they were before the new class was advocated for. Three, we usually are looking at the idea that it is a cheaper way to deliver care, which is usually temporary at best once they get that classification, and then the costs go up and reimbursement rates are asked for. But as a state obligation, I think we have to keep public safety as well as what are we doing to meet the needs of a growing state. We have a shortage in water, we have a shortage in roads, we have a shortage in teachers, we have a shortage in healthcare access. We do not have physicians and the makeup of our medical delivery teams in this state that will meet 40 million people in my lifetime. And statistics bear that out. So as a state legislature, I think we always need to be cognizant of the fact that there are different ways to do business. We have to be cognizant of the fact that it's not a motive that we need to adhere to if it's about the money. And I think that's where I'm at today, is does this scope bill make sense in the context of a growing state with a need that cannot be met under the current delivery system, nor is projected to meet if we maintain this class way of doing scope. And so that's it. I'll lay out Senate Bill 577. It's my hope to have a productive discussion over the proper role of optometrists in Texas that promotes patient safety and access to care. I have great respect for ophthalmology and optometry community, and I believe that we can come together to find solutions to address the eye care needs of Texans. I've personally been visited with ophthalmologists and optometrists in my district over this bill. I very much appreciate their willing to share their concerns and offer their expertise on this issue. Members, it is not my intention to broaden the scope of optometrists beyond their training or even beyond what is expected of them in a majority of overwhelming other states. I firmly believe that ophthalmologists play an important role in the eye care that are beyond what optometrists can provide and should provide, and ophthalmologists should be protected. However, I believe this bill is a measured approach with respect to the two roles. I would note that optometrists are the primary care providers for over 10 million Texan patients each year. They receive an 8 years of school, including 4 years of doctoral training on the treatment of eye. During that time, optometrists take years of coursework in pharmacology and disease management with oral medications. Additionally, years are spent understanding, learning, and treating glaucoma. Optometrists must pass multiple national board exams to ultimately be licensed. However, Texas optometrists have been overregulated to the point that Texas has the 6th most restricted optometry law in the country. As it relates to glaucoma, Texas is one of the only states requiring mandatory co-management at the time of the diagnosis. This causes a patient and insurer to pay double the cost and forces the patient to take a double amount of work off and make double amount of appointments for eye care that optometrists already are trained to do. Let me be clear, although this bill does not force co-management of glaucoma, optometrists must still refer patients to an ophthalmologist when surgical intervention is needed. I believe this bill is important because access to the care of issues of our state and nation are facing in our care. As of 2013 data, U.S. Department of Health and Human Services show that only 30% of the counties in Texas have permanent ophthalmologists. According to an Ocular Surgery News, pediatric ophthalmologists have more work than they can actually handle. Additionally, the American Academy of Ophthalmologists stated that ophthalmology program graduates have remained frozen over the past 20 years, and they are pessimistic that it will change while eye care demands skyrocket. By not using the full potential of optometrists to provide safe and quality care, it will only hurt patients in the long run. I filed Senate Bill 577 with three major components. It removes arbitrary restrictions on medications such as antibiotics that our optometrists already have the right to prescribe and allow other classes of oral medications needed to treat eye disease. It restored the optometrist's ability to prescribe a 3-day supply of hydrocodone for severe eye pain, something they did for 16 years before Schedule II reclassification. And lastly, it removes co-management of glaucoma with ophthalmologists except where surgery is needed. I know there's been some pushback on these provisions, but I would like to note that last month, the American Academy of Ophthalmologists and other state-supported ophthalmology associations supported and endorsed optometry legislation more expansive than this. I would encourage that both national and state ophthalmology organizations stood behind. I was encouraged that national and state ophthalmology organizations stood behind legislation that was more expansive than 577 in hopes of reaching a compromise. Unfortunately, there has not been that compromise reached with 577. Mr. Chairman, I do have a substitute. And ask that it be
Chair
laid out.
sends up, Senator Perry sends up the committee substitute for Senate Bill 577. Senator Perry, you're recognized to explain that substitute.
In the committee substitute, in the spirit of compromise, we went ahead and removed the 3-day supply of hydrocodone section and added language to ensure that all surgical cases of glaucoma are referred to an ophthalmologist. It's my understanding that some physician groups will still oppose the bill, but I would also ask them to provide possible solutions and suggestions on how we meet the ever-growing eye care needs as well as medical needs in the state under the current framework that we have in Texas, providing eye care or health care for that matter to all of the people that are coming to the state and will continue to need that care. Thank you with that.
Thank you, Senator Perry. Senators, any questions of the author?
But I would yield to our ophthalmologist, so Dr. Campbell.
I don't have questions of this. I think I'm going to be presenting the other side, if you will, so that'll probably answer questions, or you can ask.
Or we can ask the resource witness.
I may be.
We have someone from the optometry board here, and the chair will call up Chris Claris from the Texas Optometry Board.
Do we have someone from the Ophthalmologist Association? Or?
We have
You want me to
from
lay
the
out?
medical board as well.
Would you like me to
Marie
lay?
Robinson back up. She's available.
Mr. Chairman, do you want me to lay out my bill and the
You know,
resources?
that might be a good
for both?
idea, Senator Zaffarini, if that would be okay.
That'd be
It
great.
also concerns optometry,
Sure.
and we could ask at the same time. Are you okay with that?
I think it's
Right.
great. I think it's
the
good
chair
to
will
have the
leave
dialogue.
Senate Bill 339 pending. Sorry, 577 pending.
For the record and for both sponsors of the bill, I'd like to specify that my father-in-law was an optometrist and my 2 brothers-in-law are ophthalmologists. So
How
for
about
the
that?
record.
You are there in the middle.
Chair lays out Senate Bill 1718 by Senator Campbell, also concerning the practice of optometry, and recognizes Senator Campbell to explain the bill.
Thank you, Mr. Chairman and members. I think I would like to start, too, by saying that we don't want to increase the scope of practice of any healthcare provider under the guise of addressing access, even though we all recognize we've got to have more providers for the growing state. But we don't want to have increased scope of practice under the guise of increased access at the risk of quality of care. And I think that's what Senator Perry was trying to get to. We want to maintain a quality of care. The broader question here is the scope. Now, other states are expanding scope, and so you hear a lot about that. But again, I think that's a slippery slope for us to go down that has a huge risk of affecting the quality of our patient care. And I don't think I think we just have to look at that. Now, in regard to glaucoma is a devastating eye disease with no cure, and the loss of vision is permanent with this. The ultimate goal is to manage this disease so that patients' vision will outlast the life of the patient. It's very important for patients to be informed and to have research, for patients to have the research when needed, and all providers responsible for their treatment and preservation of sight be on the same page. Since 1999, Texas law has provided for ophthalmologists and optometrists to co-manage glaucoma patients. And I will say, I am a board-certified ophthalmologist, just not practicing ophthalmology at the time. I do emergency medicine. In this law, if an optometrist diagnoses a patient with glaucoma, an ophthalmologist of the patient's choice, or one in the area where the patient resides or the optometrist office is, must confirm the diagnosis within 30 days. After that, the two providers are to manage the glaucoma patient collaboratively. Doesn't always have to be a face-to-face with the patient, but the records and discussion with the optometrist and the ophthalmologist needs to be done. What this bill does is creates a co-management registry to facilitate the two providers to just more safely and completely work together, and ensures that patients don't fall through the cracks of care. So it's not taking away the care optometrists can do. In ophthalmology, we have the subspecialty requiring a fellowship, anywhere from 1 year to 2 years, to be a glaucoma specialist. So oftentimes, ophthalmologists will send, general practicing ophthalmologists will send their patients to see a glaucoma specialist. So even with regular ophthalmology practice, this is not unheard of. Ophthalmologists will, in this registry, ophthalmologists will simply enter the names and practice addresses of the optometrists with whom they are co-managing with the Texas Medical Board portal, just as they currently do for supervision of advanced practice registered nurses and physician assistants. The Texas Medical Board infrastructure is already in place and able to serve this important function. So it's not decreasing access in any way. It's asking that there's a co-management of a significant eye disease. And that's what this bill does.
Thank you, Senator Campbell.
Yes.
Senators, any questions of either Senator Campbell, or we can also lay out some. Oh, you have a substitute as well?
For this bill?
Yes.
No.
Okay, very well.
Mr. Chairman.
Senator Zaffarini, do you have a question?
I have one question. I believe that in 1999, this topic was very controversial. And of course, neither of the authors of the bill were members of the Senate or of the legislature of the House of Representatives at that time. But did you research any of the negotiations or the agreements that were made at that time? Because my understanding was that patient protections were negotiated and agreed to at that time and were not to be revisited. Of course, here we are 16 years later revisiting them. But I recall opposing some of those agreements, thinking that they were not the best decision for the patients. But did you research any of those negotiations at all?
The registry isn't the registry supposed to be there? Yeah, one of the recommendations was to have a registry then so that there would really be co-management. Technology wasn't as great then, but this is coming up because there's not a commingle of management. So what we, based on the laws back in '99, to co-manage glaucoma, I think now we need to make sure we get the registry, let's look at the data, let's co-manage before we go forward with other things.
And my question to the resource witness will be, have those patient protections that were negotiated then been implemented, or was that law ignored?
Mr. Clares, Texas Optometry Board, is that?
Yes, sir. My name is Chris.
If you would also please fill out a witness card for this bill as well as, I think you did it for 577.
Yes, sir.
I appreciate it. Go ahead, please.
My name is Chris Clares. I'm Executive Director of the Texas Optometry Board.
Ms. Robinson, if she'll come up, please. Then if you'd like Senator Zaffarini to repeat your question, or if y'all heard it,
Or I'll
that'd be
yield
great.
to Senator Campbell if
Oh.
she has questions.
Pardon me? Did you?
If you had questions.
No, do you see any problem with truly co-management? Do you see access being taken away from optometry?
I don't know if I'm the Executive Director of the Board, if I'm the right person to answer that.
Okay.
Well, Senator Campbell, the bill that is going to require the registry shouldn't really change, shouldn't have an effect on access. At least the effect that the board thinks it's going to have is just a provision of information that we will put on our website to really be able to allow the public to see the existence of that co-management relationship that you referenced that was created in 1999. And we believe we'll be able to do this within the resources we already have. So it shouldn't affect the relationship that already exists. It's just bringing that relationship public so that everyone who needs it can access it.
Could you please state your name?
I'm sorry?
Could you please state your name? For
Oh,
the
I'm
record,
so
please?
sorry, Senator Shortner. Mary Robinson, Executive Director, Texas Medical Board.
I think, too, by bringing this, I'm glad you brought it, Senator Perry. I think bringing this to light, it just allows us to make sure that we are co-managing.
Senator Perry?
You guys would be responsible for handling the complaints for ophthalmologists, correct?
Yes, Senator Perry, that's accurate.
Do you have the information regarding, do you keep it in complaints per patient data, per population? Do you have data that would support the ophthalmologist complaints or referrals for medical board? Do you have that handy?
So if you're asking how many complaints we get about ophthalmologists, we can look into that for you. We don't track it in exactly that way, but we do have that capable of being mined out of our database. When we did do an analysis several years back, ophthalmologists did not receive a higher or necessarily lower rate of complaints than the general population.
Is it fair to say that you do have some ophthalmologists that are legitimately providing a substandard of care?
I would assume that across the board, regardless of specialty, there will be physicians who are may not be following the laws that are, but obviously they would be the vast minority.
Thank you.
Senators, any other questions of these? Senator Zaffarini?
And I apologize, I'm having trouble listening. We don't have the best acoustics in this chamber, and so it's difficult. I didn't understand everything you asked.
What I asked were, there's always this perception in scope issues that as you expand your quality of care to that other group that's asking for the expansion is not as quality of a provider. My point with the question, and I can ask someone that's on the optometry board, you have bad actors, if you will, or people that fall short of expectations with quality of care, no matter what your classification or training may be. So it always comes back to the individual provider doing what they're called to do in a professional manner. I do argue that there are training limits, for sure. But I've heard the argument these optometrists are not quality providers. They shouldn't be providing care. The truth of the matter is probably 99% of our population, the only eye care exposure they're going to have is at an optometrist, maybe in a Sears outlet because it was handy. Mm-hmm. So I'm cognizant of the fact that not many people get the opportunity to visit an ophthalmologist, but the argument that there's substandard care just because they did not change or did not have their titles to optometrist to ophthalmologist. In your example, I would say that you provide, your relatives are both quality care providers, they're just a different level of care. Mm-hmm. And there's been this kind of a general theme out there that optometrists are not quality care providers. And I just want to make the point that there are people that fall short of standard of care on both sides.
Well,
Thank you.
I don't think, Mr. Chair,
Senator Campbell.
I don't think that I'm most certainly not saying that
No, you're
they don't
not.
play a primary role or their care is substandard in any way.
Right.
What we're looking at specifically with this, a glaucoma registry, is, an eye disease that is essentially silent. As the cup deepens and the visual field is lost, it's easy to miss advancement of glaucoma, and it doesn't cause eye pain as a general rule unless it's acute. And this is just asking for co-management. I don't think it's placing a blame on anyone. There's bad apples out there, and so far as access, sometimes patients cannot get to an ophthalmologist.
Right.
So I think the registry provides a way to show co-management without necessarily having to have a face-to-face.
No, and that reference wasn't to your bill. It was just through dialogue, through talking to multiple people on both sides going through this bill process. So,
And
Thank
I
you,
don't-
Senators.
I don't think this
Senator
speaks to...
Zaffarini.
Yes, now it's my understanding that the current law requires regularly monitoring the progress of the patient in the jointly development treatment plan. Has that been done, or is that law from 1999 being ignored? And if it's being ignored, is that the reason that we have this legislation proposed today?
So if you're referring to 351.3581, you're right that the law absolutely built in all of those safeguards. However, because we are a complaint-driven authority, we're not going to know whether these safeguards are going to be played out on a statewide basis. We're only ever going to know if a patient knows to complain to us that they believe this co-management actually did not occur. And that can be difficult because oftentimes the average person on the street doesn't know necessarily what the laws are surrounding co-management of glaucoma or practice of medicine in general. We can certainly research the database and let you know what number of complaints we receive, but I can tell you anecdotally it's not necessarily a high percentage, but if the effect of the bill would be to put that public information out, so should a patient or member of the public want to see that, they would be able to know where that would go. But it wouldn't change the standards or the safeguards that are already there, Senator Zaffarini. Those would continue on as they were adopted in 1999.
Right, and that's why I asked if we had a resource witness representing the ophthalmologist perspective. We do not?
We have a number of association witnesses. They're not what I would call resource witnesses. They're advocacy witnesses. I'd prefer to wait until public testimony comes regarding those witnesses.
All right, could the other witness respond to my question?
From the optometrist.
Senator, it's my understanding that it's up to the ophthalmologist and the optometrist in the co-management situation to determine how the treatment should be done. The board does accept complaints. The board has investigated complaints in the treatment of glaucoma and, where appropriate, has disciplined doctors.
Now, the 1999 law was negotiated extensively, and as I said earlier, I disagreed with some of the agreements that were reached at that time. Nevertheless, that is what happened. And so I feel like we're asking the same questions today. And a related question is very simply, did the optometrist and ophthalmologist negotiate any legislation or any agreements related to this legislation?
I was not aware of the negotiations that took place.
And if there had been negotiation, you would know?
Not necessarily. Not as
No?
executive director, no.
Okay, thank you. Thank you, Mr. Chairman.
Senator Campbell, you had other questions?
I didn't know that there's a Dr. Pierce is here from Ophthalmology Association, so he might just come up and you can ask questions of him. Is Dr. Pierce is here?
He'll have his opportunity during public testimony.
Okay, that's fine. We can ask questions.
Mr. Claris, I have a question for you. The revised bill committee substitute of Senator Perry's states that optometrists shall refer the patient to an ophthalmologist if surgery is deemed appropriate or potentially needed. Is that your understanding of the substitute?
I'm sorry, I have not seen the substitute, Senator.
You haven't read the substitute?
No, I have not.
Okay. Is that correct, Senator Perry, that that's what your substitute does?
That's correct. It just reaffirmed the commitment that any surgical needs as identified would be referred. It reiterated, especially in the glaucoma area.
Thank you, Senator Perry. Do
Yeah,
optometrists train in surgery?
In some instances, it's my understanding they do. I'm not an authority on the optometry schools.
You're the executive director of the Texas Optometry Board.
Yes, sir.
Do they train in surgery in the state of Texas?
They may in some instances. I'm sorry, I don't know what the curriculum is in the schools.
Well, they qualified or licensed to practice surgery in the state of Texas.
Can they qualify to practice surgery?
Are they licensed to practice surgery in the state of Texas?
No, they're not licensed to practice
And
surgery.
how are they able to make a determination if an individual needs surgery if they don't train in surgery, nor perform surgery, nor are licensed to perform surgery?
I mean, as executive director, I'm administering the administrative functions of the board.
You are enforcing the laws of the state of Texas regarding the practice of optometry.
Yes, sir. And if there is a complaint about standard of care issues, then optometrist members on the board provide expert witnesses. The board can reach out to expert witnesses like other health licensing agencies.
But as executive director, you should know the laws regarding the practice of optometry in the state of Texas, correct?
Yes, sir.
So how does an optometrist who has neither trained nor practiced surgery decide whether or not a person needs surgery and refer a person to surgery?
Just my personal opinion, that would be with any healthcare provider who does not practice in that area and who's required to understand their care issues to refer a patient to a specialist.
For determination.
Yeah.
But I've had many people, I'm a surgeon, referred to me that were told by their primary care physician that they need surgery and they need to go get it right now, but when they come to see me, that's the last thing they need. And also I've had the exact opposite happen, in which an individual absolutely needs surgery, but a primary care physician has sat on that patient for days or weeks, even months, to their detriment. So without referring that patient to the appropriately qualified individual to get that care. And my understanding from reading the substitute is that that might potentially be the same type of situation when an individual that's not qualified, nor trained, nor licensed to perform that type of intervention is making the determination as to whether or not they need that procedure. Is that not a reasonable thought process?
Well, maybe, Senator, but again, to my answer, that would be the case for many types of health professionals.
Okay. Just because it's okay with other health professions, it should be okay with optometry then?
Excuse me, I can't hear.
Just because it's okay with other health professions means it probably should be okay with optometry?
No, I just believe that that's the current situation.
Okay. Thank you, sir. Appreciate your testimony. Any other questions of this?
I do have a question.
Senator?
It's kind of a follow-up. If I go to my primary care and I obviously may have a fracture or not that requires surgery, primary care would not be the price to do the surgery, correct? In your what you've stated, the primary care physician wouldn't be doing the surgery on the I've had 3 knee surgeries. Primary care didn't do it. One of them I was referred by a primary care to an orthopedic. So that would be the process you would see in an optometry setting. And that 577 doesn't impact what's going on today, which is where an optometrist may refer for surgery. So 577 didn't change the scope or the intent of an optometrist. Today, they're not allowed to do surgery. That is the correct answer. They're not surgeons. And if they believe there is a surgical need, they are obligated, I think, by medical ethics to refer that to a surgeon. So the analogy that an optometrist is different in that standpoint is unique. Not, I mean, they're not unique. Is that what you were saying? Basically, the optometrists are not surgeons. They have a moral obligation to refer that to someone that does surgery.
An optometrist cannot perform a procedure because of state law or because of their abilities. They're required by standard of care that the board enforces to refer that patient.
And what I heard in your testimony, as feeble as it was, that is the correct call. They're not surgeons to refer it to a surgeon, and that's not unique to optometrists. Other medical providers would refer to surgeons.
That's my understanding.
And they may miss the diagnosis, which is not unique to optometrists, too.
Thank you, Senator Perry. Any other questions of this panel? Senator Zaffarine.
Actually, I have a question for Senator Perry regarding Senate Bill 577. Looking at the
I'm going to go ahead and lay out Senate Bill 577 again so you can ask that question. Go ahead, Senator Zaffarine. Thank you.
Thank you, Mr. Chairman. Looking at the bill analysis in paragraph 4, it says Senate Bill 577 seeks to remove the restricted oral medication formulary so that an optometric glaucoma specialist may use all oral medications appropriate for treatment of the eye for any time length medically necessary. Is that still true in the committee substitute?
The committee substitute removed specifically the hydrocodone, which was one of the initial emphasis in the bill was to be able to prescribe hydrocodone. I understand the addictive qualities of that drug. It was a 3-day supply. It was something they used to do prior to a federal reclassification of that drug category. And the way it was explained to me is the side effects, believe this or not, which was kind of interesting to me, were less detriment than the alternatives that they currently are prescribing for eye pain. So that was the drive, but under the committee substitute, the 30-day supply of hydrocodone has been removed.
I see.
They currently are able to, under my understanding, and witnesses can support this in a more detail, antibiotics and other eye pain medications.
I see. Thank you. And then in paragraph 6 of the bill analysis, it says that the bill seeks to repeal regulations that require a mandatory consultation with an ophthalmologist at the time that a patient is newly diagnosed with glaucoma. Does a committee substitute change that at all?
The committee substitutes reaffirms the surgical application for glaucoma, so it does lessen, if you will, that co-management relationship.
And then in the last paragraph, it's on page 1, it says it would allow optometric glaucoma specialists to treat glaucoma without mandatory consultation at the time of diagnosis. That is still true?
Still in the bill.
Okay. Thank you. Thank you, Mr. Chairman.
Thank you, Senators. Any other questions of Senator Perry? Senate Bill 577 be left pending. Any other questions of Senator Campbell regarding Senate Bill 1718? If not, Senate Bill 1718 will be left pending. Chair lays out Senate Bill 1899 by Senator Campbell and recognizes Senator Campbell to explain the bill. I believe you have a committee substitute. Senator Campbell will go ahead and send that. You'd like to send that committee substitute up, and
Yes,
Chair
sir.
recognizes Senator Campbell to explain the substitute and the bill.
Thank you, Mr. Chairman and members. Currently, EMT paramedics or licensed paramedics may work in ERs as ER techs. Paramedics do possess a unique set of life-saving skills and training that can be useful for specific emergency situations. SB 1899 addresses this issue by allowing paramedics to provide certain advanced life support services in specific emergency situations within a hospital. Under the bill, a paramedic may provide advanced life support services under the supervision and delegation of a licensed physician in a
captain in Dallas testified that he had personally rescued victims of trafficking that had been coerced into abortions in order to keep them working as sex slaves. It's a real issue and we need to pay attention to it. But this situation, we need to do more in this situation, not just give abortionists and his staff a one-time training on what human trafficking is. The Texas legislature has never trusted abortionists or their workers to be the authority on their discretion, and I don't think we should start here. Right now in Texas, it is not explicitly illegal to coerce or force a woman to have an abortion. So at the very least, this bill needs to make that act itself illegal to force a woman to undergo an elective abortion. Senate Bill Senator Colkhorst has filed a bill that does that and more, that it handles this issue more adequately. I'll point you to, it makes coercion illegal, and it actually puts in protective measures to stop the coercion and give that woman protection she needs. So, Chair, I'll answer any questions you have.
I apologize for not pronouncing your name correctly earlier.
That's all right.
Senators, any questions?
I just have one question.
Senator Perry.
You not being a medical physician, nor was the last witness with her analogy, would you agree that pregnancy centers do health care for the mom and the baby?
Some in the state of Texas do. Yes,
Okay,
sir.
thank you.
Great. Thank you. Mr. Segal, thank you. Is Dr. Jeff Patterson in the audience? Anyone else wish to testify on, for, or against Senate Bill 1873? Hearing none, public testimony is closed. Senate Bill 1873 will be left pending. Chair is going to lay out the two optometry bills at the same time, as there are some witnesses that are on both bills. Chair lays out as a matter of pending business Senate Bill 577 by Senator Perry, as well as Senate Bill 1718 by Senator Campbell. Senators, there are 5 individuals which testify on each bill, but 3 of them are testifying on both. So we're going to call those 3 up first. The chair calls Dr. Thomas Lucas, Texas Optometric Association; Jane Edmond, Texas Ophthalmological Association; and Dennis McNaman, representing himself. He's a retired deputy sheriff. He's against the bill. Senator Zaffarini, there are 12 individuals registering but not testifying on Senate Bill 577. And there are 9 individuals registering but not testifying on Senate Bill 1718. I'll accept motions to enter those into the public record.
So moved.
So moved. Anyone against that motion? Hearing none, is so ordered. Dr. Lucas, welcome. Please state your name and begin your testimony.
Thank you, Mr. Chair and committee members. I'm Dr. Tommy Lucas, and I'm the president of the Texas Optometric Association. Are we speaking for 577?
Yes, you can speak on 577 and 1718. You had witness cards on both, if I remember
Correct.
correctly. Begin.
Okay. I'd like to testify in favor of SB577 by Senator Perry, and I'd like to thank Senator Perry for bringing this very good bill that addresses patient access in eye care. First, let me describe about the landscape for eye care in Texas. We have roughly 4,000 optometrists in Texas, and we provide approximately 70% of the eye care in this state. We're the state's main source of primary eye care, examining and treating approximately 10 million Texans each year, roughly 1 in 3 Texans. Optometrists go through rigorous doctorate training for 4 years after their 4 years of college. During that time, we study every aspect of the eye and its relation to the body. The reason this bill was brought forward is because Texas is lagging seriously behind in patient access to primary eye care by optometrists. My colleagues and I are forced to practice under the 6th most restrictive law in the country for optometrists. This overregulation of optometrists creates many inefficiencies in my practices and in helping our patients with their eye problems. I want to be very clear, this bill only does 2 things. This bill removes restrictions on oral medications used to treat eye disease, and it removes restrictions on glaucoma co-management. There's no hydrocodone in this bill in the committee substitute any longer after discussions with your office, Senator Shortner. And I would like to close my testimony by reading you something that will be important in the discussion following, and it's Section 351.360 of the Texas Optometry Act. It states, a therapeutic optometrist or an optometric glaucoma specialist is subject to the same standard of professional care and judgment as a person practicing as an ophthalmologist. In other words, it doesn't matter if an optometrist or an ophthalmologist is treating a patient, we have the same standard of care.
Thank you, Dr. Lucas. Questions of this witness? Senator Campbell.
Hello, Dr. Lucas.
Hi, Dr. Campbell.
Do you co-manage right now glaucoma patients with ophthalmologists?
Yes, ma'am.
Do you really see a problem with that?
My situation is a little different than some of my colleagues.
How so?
I practice in a practice where I co-own a practice with an ophthalmologist, so I have very easy access in my locale to talking with an ophthalmologist about a glaucoma patient.
But do your patients always see the ophthalmologist?
Rarely.
Okay, so it's still a co-management if you have a question or records, you co-manage glaucoma. I think what my bill does is it's just addressing co-management of glaucoma, which as an ophthalmologist I think is just a very important eye disease, and having a second look, second set of eyes, specially trained for glaucoma especially, but ophthalmologists who have an additional 4 years, I don't think that's asking too much, and it's not taking away any patients from optometrists. So just asking for that extra layer of protection, I just fail to see here how that infringes or takes a bite out of patient care. So help me there a little bit.
Senator Campbell, respectively, I disagree that 1718 will further the goals of glaucoma treatment in Texas. What we really have here is a tale of two cities. We have...
Well, let me just, without getting into a long story, my question is, how does co-managing take a bite out of the optometrist's care for the patient or their patients? We're just asking a co-management here with somebody who has a specialty.
The magnitude of that bite is determined by the ophthalmologist. So in other words, sometimes a face-to-face is required, or in another situation like my situation, I can pick up the phone and call the ophthalmologist and say, hey, I have another glaucoma patient here.
The registry does not require face-to-face. It's a registry.
Correct, but that doesn't mean that every optometrist will have access to an ophthalmologist that won't require face-to-face.
Well, optometrists have options to work with other ophthalmologists. So again, members, I just fail to see how that can't be co-managed and what the problem is there. I most certainly believe that within your scope of practice, you're very good. I just really don't have any problems with that, and I've got friends that are optometrists, so that's not the problem. And even an ophthalmologist, we just never have, we don't have an adversarial position there. So I don't really need other comments. I just wanted you to know what this is and how I feel that we're putting the patient first here. And let's make sure we don't lose sight of that. Thank you, Mr. Chairman.
Thank you. Senator Zaffarini.
Doctor, do the ophthalmologists with whom you work support this legislation?
They're indifferent. In the discussions with my partner and other ophthalmologists I know, they see all of this as somewhat of a circus that we conduct here at the Capitol. In the real world, we get along very well with ophthalmology, but that doesn't limit the access problems that we have with finding co-managing ophthalmologists. The reason we're opposed to Senator Campbell's bill is because the real-world effect of her bill will be to completely destroy optometric access to glaucoma patients. In other words, patients won't be able to receive care from their optometrist any longer because when that registry is out, there have been polls taken by ophthalmology prior that over 90% of them don't wish to co-manage with an optometrist. So if that poll is consistent with what we've seen, then the optometrists are going to have much difficulty finding an ophthalmologist to work with when they're publicly identified.
Go ahead.
I just don't buy that.
Senator Perry. Oh, I'm sorry, Senator Zaffarini.
So-
That's okay. I'll yield. It's okay.
I'm sorry. Please, Senator Zaffarini, continue.
Thank you. The 1999 bill was negotiated extensively and thoroughly. What happened to that agreement? Why did it break down?
Senator Zaffarini, I'm 34 years old. I graduated high school the year after that happened. I do serve as our legislative chair, and I've been told of how that went down. I understand it was a political compromise that first gave rise to the optometrist's ability to treat glaucoma in 1999, along with prescribing oral medications as well. I understand those were intense negotiations. I think from that, I was told, I think either a 2 or 3 session moratorium was placed on scope of practice issues for optometry following that, but I can't speak to certainty about that.
So was there any discussion or negotiation between optometrists and ophthalmologists regarding either or both of these bills before us today?
Yes, ma'am, attempted negotiation. The process had cold water thrown on it in the very beginning because ophthalmology stated they would not negotiate or would not bend or anything in a public letter to the legislature. Since that time, we did have one meeting on the House side for about an hour, and again, no resolution was reached.
So basically what we have before us is another scope of practice issue.
What we have before us is a practicability for optometrists that matches what the rest of the country already does for optometry. 44 other states allow what's in this bill.
Which in our lingo would be a turf battle. Is that correct?
Correct.
Thank you.
you could characterize it as a turf battle.
That is what we would call it. And that's what we required. We demanded, in fact, negotiation in 1999. And it seems to me that that would be best because it basically boils down to a turf battle. And what we have to insist is that we do what is best for the patient. That
Absolutely.
the patient has to be first. Not what is convenient, not what is best for one group or another of providers, but what is best for the patient. How do we ensure that patient's safety? Thank you.
Mayor,
Thank you, Mr. Chairman.
Senator Perry.
So, a couple of things. You made a comment that you would call your ophthalmologist on a glaucoma. Is it fair to say that most optometrists faced with glaucoma would, number one, always have that discretion, but number two, if they felt like it required additional consult, which I would hope that glaucoma rises to the level of seriousness because of its devastation, that most optometrists would feel the need to have that consult if there was something they felt very much needed that consult. I mean, there's nothing, y'all are not told in optometry school, don't call the ophthalmologist.
No, sir.
It's not something, in fact, the business, I would assume. Can you tell me what your training on glaucoma treatment looks like?
Yes, sir. Again, we work together collaboratively across all manner of eye disease with ophthalmology. What we have is basically optometrists taking care of primary eye care disease in a large capacity in the state, and then we have ophthalmology that handles mostly surgical cases. And as the demographics play out and the demand for eye care surgical cases rises, ophthalmologists are going to be very busy and almost entirely busy just performing surgical cases. This is based off demographic studies of increasing elderly and minority populations, of course. I'd like to go back and state that we're under the same professional obligation to treat that patient correctly. So in other words, if I make a mistake in my glaucoma treatment on one of my patients, I'm held equally responsible to an ophthalmologist. There's nothing in an optometrist's psyche or otherwise that does anything other than puts that patient first in that situation. I echo Senator Zaffarini's comments on that. This is a patient-centered bill. I can explain that by simple cases. If right now I cannot prescribe oral acyclovir, which is an antiviral drug used to treat various viral entities of the eyes, eye infections. That patient needs that medication within 48 hours or they have the potential to scar down on the front of their eye. This is a very safe medication. Optometrists have had hundreds of hours of pharmacology training in our studies and our doctorate programs. And when we can't treat that medication, or we use that medication, it's the patient that suffers in that instance. I often have to reach to non-physicians, to non-physician prescribers to get that medication, nurse practitioners, physician assistants. And of course, these are folks that aren't trained in the eye, and they take my recommendation, of course, to prescribe that medication, in this instance, acyclovir.
There's been a designation mentioned that ophthalmologists sometimes receive is specific to glaucoma. It's a subset, if you will, ophthalmology. And even ophthalmologists have said they'll refer glaucoma to that specific designation. But can you tell me, or you may not know since you're in the optometrist side, how many actually have that designation and specialist or specialized in glaucoma? Because again, we get down to it may be available for 100, but when you're talking 10 million, that's the issue of the day. At some level, having access, and I've got a map here, and it shows pretty much all rural Texas has no ophthalmologist at all, and very few optometrists access. So we do have to accept the fact that quality of care is number one, standard care is number one, but even as a subset of that, having no access to anybody is probably just as dangerous as not having the absolute standard of care met at all costs. You're a frontline provider. The Academy of American Academy of Ophthalmology endorsed bills that are more expensive than Senate Bill 577.
Correct.
And do you know how that has evolved? And we are getting doctors from other states, optometrists, that were able to do so many of these other things, and they're coming into our state and they can't practice effectively the same way they were. But can you address why the Academy of Ophthalmologists have come on board on a multitude of other issues?
I can't speak for the American Academy of Ophthalmology.
We have a number of witnesses
we've
that are
got
from that
somebody.
association.
Yes. Can I respond? So I do. I have repeated that optometrists practice under the sixth most restrictive practice authority in the country right now. Each of Texas's surrounding states practices under much more than what is in SB577, including Louisiana, Oklahoma, and New Mexico most recently. What is somewhat ironic is the practitioners that go to these states don't have optometry schools, so most of those practitioners are training right here at the University of Houston College of Optometry and the University of Incarnate Word in San Antonio. So in other words, the doctors that we're training here with Texas tax dollars, those doctors are simply going across the borders to practice optometry the way that they're trained to.
Thank you, Dr. Lucas. Senators, any questions of this witness? Very good. Dr. Edmond, Texas Ophthalmology Association, please begin your testimony.
Thank you for having me, and thank you, Chair Schwartner. My name is Jane Edmond. I'm a pediatric ophthalmologist and a pediatric neuro-ophthalmologist. I have 25. I've been out of my training for 25 years. I practice at Texas Children's Hospital, and I'm here to oppose SB 577. Children also get glaucoma, and it is not the same type of glaucoma that adults get. It occurs at 2 times. It can occur at birth, and it doesn't become apparent till the first few months of life. It looks like a blocked tear duct, actually, and can be missed. The second wave is in younger toddler and beyond, and it often occurs secondary to diseases that affect other parts of the body, like juvenile rheumatoid arthritis. It can present in the eye. The children don't complain. They may have a little joint tenderness, but they don't know that they're having a problem, and so those patients develop intraocular inflammation and often very dangerous glaucoma. Also, glaucoma occurs secondary to steroid use prescribed by other practitioners for asthma and autoimmune diseases. The children are different in terms of the type of glaucoma, but they're the same as adults in that they go blind from glaucoma and mistreated or undertreated glaucoma. I am referred many children a year by optometrists with a diagnosis of glaucoma, and probably 9/10 of these children simply have large optic nerves. It's called physiologic cupping or megalopapillae, and it is not glaucoma at all. So if our partnership was removed from taking care of patients with glaucoma, these children would be placed on eye drops that cause their eyelashes to grow big and bushy, to cause their color of their eye to change, to have red eyes, uncomfortable eyes, possibly all secondary to the treatments of glaucoma, which are not benign. They're absorbed into the eye and the body. These drops would be given inappropriately to these children if we were not there on the team.
Thank you, Dr.
So this
Edmond.
highlights the need to keep ophthalmology as a part of this.
Senators, any questions of this witness?
I think just the comment that, once again, when you start moving out of your scope of practice and training, then we can just have problems. Putting the patient first is important. Thank you.
Thank you, Senator.
Thank you for your
Dennis
testimony.
McNamara, please begin your testimony.
Thank you, Mr. Chairman, committee, for having me. I'm here to oppose this bill. I am a glaucoma victim. I went to an optometrist for over 20 years. He failed to diagnose and inform me that I had glaucoma for a number of years. I lost a significant portion of vision in my right eye, which ultimately resulted in me having to retire from my career earlier than I anticipated. And at that time, I was unaware of the difference between an optometrist and an ophthalmologist. The optometrist only once in 20 years did a dilated eye exam. He never referred me to an ophthalmologist, as is required by state standards. I'm a lay person. I'm not a doctor. It seems to me that trying to do what the optometry people are trying to do is lowering of standards, and anytime you lower standards, you get a lot less quality of care, and I, for one, don't think that anyone's vision or their health should be subject to lowered standards.
Thank you, sir. Any questions of this witness or this panel? Thank you. Senators, there are some witnesses left, 4 witnesses total between Senate Bill 577 and Senate Bill 1718, but we do not have time based on the session. So I'm going to leave pending Senate Bill 577 as well as Senate Bill 1718, and we will re-adjourn after, we will stand in recess subject to the call of the chair. Thank y'all. Senate Committee on Health and Human Services will come to order. Members, we were in the middle of public testimony. We have just a few more witness cards on the optometry bills that we had, and so therefore, and then we have 4 more bills thereafter to hear public testimony on. I don't believe this will take more than about 1 hour, members. Chair lays out as a matter of pending business Senate Bill 577. Chair lays out as a matter of pending business Senate Bill 1718, which were the optometry bills. I don't know if these individuals are still with us, but I will go ahead and call their names. The chair calls Dr. Harrison Bowes, Texas Ophthalmology Association. Dr. Soheil Daftarian, Texas Ophthalmology Association. Chair also calls Dr. Jack Pierce, Texas Ophthalmology Association, and Dr. Steve Wynn, representing himself. If any of those individuals are here, please, great, y'all are. Please state your name and begin your testimony.
Go first. Go ahead.
Hello, I'm Soheil Daftarian. I'm an ophthalmology resident in Lubbock, and I'm here in opposition to Senate Bill 577. I'd like to thank Dr. Schwartner and the committee members for your time, and thank you to Senator Perry for allowing the stakeholders a chance to be heard at the table. An important realization I've made during my learning process is that conditions that seem simple enough early on revealed themselves later on to be much more complicated than I previously thought. When I look back at how much I knew a year ago and a year before that, I'm amazed at how much I didn't know that I didn't know. It's deceptively easy to oversimplify glaucoma and other eye conditions, but the disease and its effect on patients' lives is far from simple. One of the most important lessons we learn in our years of training is the art of knowing when to refer a patient to a higher level of care. And the failure of knowing when to refer a patient was illustrated by a patient I saw not long ago in the ER while on call. The patient had a traumatic foreign body in his eye. His optometrist managed the patient alone for a week without consulting anyone before finally sending him to our ER. The optometrist managed the patient by scraping with a needle the cornea or the clear front surface of the eye, all the while thinking that the object was on the surface of the eye, not realizing that it was within the eye. The patient needed immediate hospital admission, IV antibiotics, and emergent surgical removal of the foreign body, but he was denied that standard of care and suffered permanent vision loss because of the delayed referral, because his optometrist didn't know what he didn't know. And the failure of knowing when to refer was also seen in Palo Alto in 2009. When 110 out of 380 glaucoma patients taken care of at the VA there, while under the care of their optometrists, lost permanent vision that could have been prevented if they were under the care or if they were referred to an ophthalmologist. Their optometrist failed to identify when they had advanced to moderate and advanced levels of glaucoma, and failed to follow the guidelines that they were given to refer to an ophthalmologist. And this all shows that we need to tighten and enforce the laws we already have rather than...
Thank you very much for your testimony. Senators, any questions? Thank you. Please state your name and begin your testimony.
You want to go?
Go ahead.
Hello, Dr. Schwartner and members. I am Dr. Jack Pierce. I am an ophthalmologist, retina specialist here in Austin, and I'm here today to speak in favor of Senate Bill 1718. That's the registry bill that Dr. Campbell has laid out so nicely for us. As you know, since 1999, we've been co-managing glaucoma patients with the optometrist, yet there's not been a registry available during that time. We think that it would make it a lot safer for all of the patients if we did have this registry bill. We believe that the registry will allow patients to access the names and all the providers, both the optometrist and the ophthalmologist, and so they know who is really co-managing their glaucoma, so they can reach them if they have a problem late at night or whatever. This will be easily available through the Texas Medical Board's portal, and we would like to thank Dr. Campbell for putting this forward. Any questions for me, please?
Thank you, sir. Any questions of Dr. Pierce regarding Senate Bill 1718? Thank you. Please state your name and begin your testimony.
My name is Harrison Bowes. I'm a fellowship-trained glaucoma subspecialist in San Antonio, Texas. Shout out to Senator Uresti from Quincy Avenue. Our offices are on the same street, downtown San Antonio. I'm in opposition to Bill 577. As Senator Campbell outlined, glaucoma is a devastating disease. It can lead to permanent blindness. And as a glaucoma subspecialist, I feel like I'm doing well if I can keep the patient seeing throughout their lifetime. My object is, frankly, that they die before they go blind. That's how serious glaucoma is. And I have some major concerns with 577 and basically striking through the safeguards that were in the 1999 co-management bill, specifically the need to confirm the diagnosis of glaucoma within 30 days with an ophthalmologist. I don't feel that optometry is doing this currently. This can lead to harm to the patients where they're overtreated when they may not necessarily have glaucoma. It can lead to cases where they're undertreated and they're sent to us far too late when there's already significant damage done to their eyes. I'm concerned also that within 577, or within the 1999 bill, there was safeguards for optometry to refer to ophthalmology when patients weren't responding to therapy. And that's very important to prevent the progression of the disease. Also, unless you're a surgeon, you don't know necessarily, as the chairman pointed out, when is the time that medical therapy has failed and when you need to proceed to laser, when you need to proceed to surgery. And if you had two heads instead of just optometry without the proper training, I think it would be in the patient's best interest. Thank you.
Thank you. Senator Zaffarini.
For any of the three or all of you, if 577 were to pass, what would be the impact on the health and safety of the patients?
I think patients will go blind. We had earlier testimony in this morning of a sheriff who lost his livelihood because his diagnosis of glaucoma wasn't made for 20 years. So this affects patients' livelihood. It affects their quality of life. Economically, I'm going to see the same number of patients whether or not this passes. For us, it's not an economic issue. It's not a turf issue. We don't want to take away patients from optometry. We're concerned about patient safety, and we think it's lacking.
Thank you.
We need to only look at when this experiment was run already in Palo Alto, when 110 out of the 380 patients lost visions, ranging from partial visual field loss to permanent blindness and total blindness in one eye, when the optometrists were taking care of them without following guidelines and properly referring them to a higher level of care. And so it's already been seen what would happen if this is allowed. And the fact is, it would lead to unnecessary compromise in patient safety and loss of vision.
Thank you.
I would agree with the other two doctors. I think we're really looking for transparency when it comes to the registry bill. As far as 577 goes, indeed, I agree with them. I think we need to be very careful in what we're doing, and we're really looking for patient safety.
Do you know of any ophthalmologists who are supporting Senate Bill 577?
I know of none.
No.
Thank you.
Mr. Chairman.
Senator Perry.
Just real quickly, and I want to clarify a few things. Number one, your VA example is a bad example because it's a VA example. Our level of care extended to veterans is subpar at best, and we failed miserably. And to have any healthcare provider in that system under the restraints they operate under, or probably the bottom end of the spectrum of provider, I'm not shocked that there's not good results. at the VA system. We have a better solution, but we have a government that doesn't want to react to it. So the VA example is a little bit hollow. Number two, you hit on it, and I very much appreciate. It's not a turf battle for me. As a legislature, we're brought these ideas. We don't sit around and dream up things to do. We don't make this our bailiwick of the session. We've got plenty of other things to work on, too. I have and I don't disagree with anything that's really been said on either side of this equation today. But I do think we have to begin always with patient safety, but at the same time, how are we going to meet the needs going forward? We truly, truly have, in my opinion, not only in this area, an manned area going forward. So, what I've learned through these scope debates, and it's not unique to the optometrist and ophthalmologist, there is internal strife that if they would work together, we would serve the patient better. And the divide in y'all's group seems to be deeper than what I remember 4 or 6 years ago when this stuff came to me. And the lack of co-management because of perceived turf battles or partnerships, quasi quid pro quo arrangements that exist or don't exist formally or informally, they all are out there, and they were all disclosed to me in conversation with ophthalmologists and optometrists. So this is not a lecture in the sense of, I'm just saying these organizations, be it optometrists or ophthalmologists, be it nurses or physicians or PAs or NPs, at some point it's got to set aside what they think they should be able to do and start doing what they're supposed to, but at the same time begin this association that we envision be a healthcare package. Because what I've seen through this debate specifically is not unique, and it continues every session to get a little deeper and a little deeper. But there's not a coordination that's healthy for the patient at the end. And only you guys can fix it. Because if we continue to go down this road as a legislature, it gets messed up worse. So I'd encourage you to think as association. Back to Senator Zaffarini's question, the American Ophthalmology Board did support provisions and bills across the country that are very, very much more expansive than 577. So the Association for Ophthalmologists do support measures across the states in more of a expansive capacity. So again, I get mixed results. Some people on the ophthalmology side say yes, some don't. Optometrists want more, they don't. So it's this internal strife that I have removed myself going forward from, and I won't be a referee for organizations in these areas any longer. But that doesn't excuse you guys from getting together and figuring out how best, and then bring solutions that we can interact with on a productive basis.
Thank you, Senator.
Sorry,
Senator Campbell.
Thank you, Mr. Chairman. And I got here late. Y'all are ophthalmologists? All ophthalmology?
Yes.
Well, and I am too. And so I missed the, basically retired since I do emergency medicine. But so I missed the conversation where was it, yeah, it was good. Okay. Because I am, I think optometrists do a good job for what they're trained to do. I'm very cautious on scope creep, and I think that, I know all the training I had to go through and chose not to do a fellowship. And, I feel like that we do offer a total package in medicine that is missing in optometry. So, yeah, it's always good to work with, always, because we can cover more ground. But I do feel we need to stand strong against giving up to those who are not as trained, because we know what our academic skill set is, giving that up to have others take it when they didn't have the same academic training. And I think this bill does very well with a co-management. And, asking ophthalmology to co-manage, I don't see that's a problem. Do y'all?
No, the one area that ophthalmology is unwilling to compromise on is patient safety.
Absolutely.
And the 1999 bill, co-management bill, was an attempt to get us to work together. And I think it can work with the proper registry, transparency, enforcement, and oversight.
Yes.
And that's a way we both can work together, and the patient's not harmed in the process.
And I think that's what I'm asking in my bill. So, okay.
Thank you, Senator.
Thank you.
Any other questions of this
Thank you
panel?
all.
Thank you,
Sure.
panel. Dr. Steve Wynn, representing himself, is